It's one thing that they don't want to leak anymore. They don't want to have prolapse, but they want to restore their health. They want to restore their sexuality, their confidence, their functionality all around.
I am lucky enough to be sitting here with Dr. Castillo today.
Thank you so much. Thanks for having me. So I'm a urogynecologist, and throughout my career, I've taken care of women's quality of life issues, but in a medical sense, meaning problems that have happened, already occurred because of life events and time. Incontinence, prolapse, childbirth-related injuries, and that combined with time leads to prolapse or pelvic pain or sexual dysfunction. And one of the things that we always dance around in urogynecology is that we only focus on the illness. We don't focus on the desires of the patient. It's one thing that they don't want to leak anymore. They don't want to have prolapse, but they want to restore their health. They want to restore their sexuality, their confidence, their functionality all around. So over the years, I recognized that it's really important to listen to the patient. If you give the patient the opportunity to express not just their needs, but their wants, you can really get to the root of what they really want. What I call a door handle question is they usually wait till the very end of the visit, just about to leave, and they'll ask you, just as you think the whole visit's over, and they'll ask you the really important question, why they were there. And those are the questions we've learned to listen for.
Do you feel like a lot of patients are searching for something like on Google, like say they have urinary incontinence or prolapse, and they kind of search, and then they end up in front of you potentially for a service, but it sounds like what you're saying is they're really looking for something more, a result instead.
A little bit of everything. My patients who are referred to me or find me because of incontinence or prolapse is because they don't know what's available for them. They just know that those are conditions that insurance covers or that their doctor referred them for. But many patients who are interested in improving their sex life, their sexual function, their confidence, they've already been to their doctors and they've already been dismissed. They've already asked about, can this improve the way sex feels? How will this impact my orgasms? Or what can you do about my libido? And it's dismissed. It's what we call, gaslit or ignored, because we were never trained to address these problems. We were never trained to discuss these problems, so we don't bring it up. And the majority of women, over 70%, expect the physician to bring it up. So if we don't bring it up, they don't bring it up, they live in silence. So because of that, patients go online.
You being a surgeon and doing the full comprehensive package for women is very unique. And so talk a little bit about that, because I think what I'm hearing, again, is what we've seen a lot of, is that they actually sometimes come in a different way. And you have your surgical patients that are showing up, but the ones that just want better sex, do you feel like they're coming in a different way to your practice?
I think patients typically don't know what's available. They don't know that there's surgical or non-surgical, they just know there's a problem. So when we put information on the internet for patients to search, we use terms that they look for. Vaginal laxity, painful sex, orgasmic change, things like that, using their terms, and they look for them that way. They don't really know what's available. So they're not even thinking, I don't think, surgical or non-surgical, though some patients are surgery averse, which is perfectly fine. The most important thing is providing options. So many providers, we train in one way, we have a limited toolbox. It's really important to have a larger toolbox so we can offer options, because not everyone's really interested in surgery. Not everyone is interested in temporizing measures. And so the goal of patients coming to see us is for a thorough, deep conversation about their wants and provide their options and how they would like to proceed.
Again, you're surgical, but you're actually expanding the tools that you can provide, because not everyone may want surgery or even need it, is what you're saying.
Yeah.
So you sit down with them and really give them all the options.
I do. And it's also important to educate the patient, not just about what their options are, because they weren't aware of them. Also, what might better serve their desired outcomes. For example, somebody who has severe laxity, probably some prolapse, and what their goal is vaginal tightening, a laser therapy is not going to cut it. It'll help with dryness. It may help with leakage, it may help with urgency and UTIs, but it can't change muscular changes. And vice versa. Someone who's never had kids, but as they entered menopause, decreased sensation, orgasmic changes, they don't have a muscular injury, they don't have pelvic floor laxity, they have skin and neurologic changes. That's where regenerative therapies come in handy. So it's really about understanding the patient's history, putting that together with what their desires are to come up with a solution.
The intimate wellness you picked for a reason, because it probably means something based on what you're offering, but also what you're hearing from patients. So tell me a little bit about what intimate wellness means for you.
Sure. And intimate wellness can be viewed several different ways. It's not just about intimacy and sex. It's also the concerns that patients keep close to their chest that they're afraid to bring up. They're embarrassed about, they think it's normal because their mother, their sister, their aunt has it. So it's really intimate to them, whatever that concern is. It could be bowel incontinence, it could be leakage, it could be appearance, right? So whatever has been a taboo in their mind that they don't share is what we're about. That nothing is taboo in our office.
Yeah, that's unique, isn't it?
Yeah. And we love being able to serve patients this way.
I loved hearing the intimate wellness, and because it's the same thing, but it's a different term. And I think that we're still in medicine very taboo about the issues that we're talking about right now. And I think that the conference we're at right now is probably the best at talking about sex, but still it's taboo in medicine overall, wouldn't you say?
Oh, absolutely. There's lots of barriers to care for why patients may not find help. Some of it is cultural, some of it is embarrassment and personal, but a large part of it is the providers themselves. Whether we're gatekeeping because we don't feel it's important enough, though we know that there's people out there that do these things, or that we don't know enough. And we're limited in our knowledge, so we think there's nothing beyond that that's just they have to accept and live with it. So it's very dismissive. And that's what we really focus on. Aside from patient care, we really educate. We offer lectures and courses, and we do all kinds of things to help elevate physicians' knowledge and awareness that these are real concerns for patients, and not to ignore them.
Again, guidelines are fragmented in how they do it. They're conservative, it's biased a lot of times, and I feel like it's not like the practice. So there's the traditional medicine model, and I think that what you're doing is innovating. I think that innovators in medicine kind of separate away from that traditional because we don't have offerings for, and they don't even talk about sex and function and arousal and all the blood flow issues that we even just talked about. There's just a mismatch in practice, right?
I think what you described really sums up the biggest problem, is that our healthcare is fragmented. It's hard to be a master of all, but at the same time to not have any training in certain areas, especially something that's as common as sex and intimacy. During the presentations today, somebody discussed, I think it may have been your talk. I'm trying to remember, somebody put up a slide about the vast majority of women we focus on reproduction. That's a small segment of, I love that slide, small segment of their lifespan. Whereas the vast majority of their lifespan and their concerns revolves around the intimacy and their needs. And why are we focusing on only those small segments? What about the rest? And when you combine that with our fragmented healthcare and the way we train, the urologist doesn't really focus as much on female sexual health or female urology for that matter. Same with the gynecologist. They may not understand sexual health to a degree that they can talk about, or urologic problems. And then the colorectal the same way, and then the family practice the same way. We all stay in our lanes, but nobody understands how important this is.
There's two types of medicine right now. It's traditional, and then it's the innovators that are kind of stepping out of that because they see a need. I mean, I'm sure that's what happens in your office, because it does for us. Like every single day, we're hearing the same thing. I went to my gynecologist, I went to my primary care. They don't listen to me. I'm not having sex, or it's painful, or whatever it is, and they just say, well, it's normal. You're getting older. And so that's a huge gap. And I think that that's just where somebody that actually can think outside of the box, like yourself, then starts to realize that there are some solutions, there's a need for it, and then you start to innovate it. Yeah.
Well, like I said, my patients have taught me.
Yeah.
They've shaped the practice and the services that we can provide for them. And all it took was listening, which was hard because the system doesn't allow us time. We're crunched for time. We have to see X number of patients per day just to pay the bills. So what does that really serve the patient? It doesn't give them an opportunity to learn. And so what are we stuck with? We're stuck with guidelines, best practices that are outdated. They're outdated. They're behind the times. They're not really up to patients' needs. They're really about patient, conditions and diseases. They wait for the shoe to drop, and that's what these guidelines are for. It's sort of like, the light that we see from the stars. That's old news. We haven't moved. We really have to push the envelope and listen to patients and, start looking for solutions that they want now.
So a third of your practice is hormones.
Yeah,
You said,
easy.
right?
Yeah.
Yeah, and it's because women want to feel better, and there's a big missing piece. What do you think about this black box, lifting, and that? Do you feel like there's even more confusion now?
Yes, and I expected this to happen because we were told for over 20 years hormones are bad. Patient women in menopause are really meant to be forgotten. And so throughout training, not only were patients not treated, but physicians were entrained. And now that there are providers like us and others that have never quite understood that rationale, we've been treating patients. We're ahead of the curve, and now all of a sudden the black box warning is lifted, which all it does is just open the gates because everybody just feel, okay, I can give them estrogen again, but they never learned how to do it. So now there's backlog and no stock for estrogen patches, and there's issues that are going to arise because of mismanagement, even though their best interest is for the patient. They haven't been trained.
We knew hormones in women, we knew they felt better with hormones, but then they did a governmental study to see if it was safe, right? And in 2002, we shut it down. And like you said, 20 years to lift that back up. But hormone specialists, people that have actually, trained in hormones and how to treat women, have filled the gap, but with compounding options as well, right? But the guidelines still recommend against compounded. So I think that's interesting because that's what's filled the gap for 2 years. And so I feel like the patients are more progressive and they're looking for solutions, and the solutions have been compounded options.
Yeah.
Because that's what we have. Even with testosterone in women, there's still no product for that. And so isn't it interesting that, again, that's where the institution becomes so big that I think it's even confusing. So patients, to me, are looking like there's a black box. So the black box, the FDA is now approving hormones. So everything should be covered.
Right.
That's the other, I think, chaos.
Right. And because doctors weren't treating them, patients assumed it wasn't covered. It was always covered. Estrogen was always covered for women. However, doctors' hands were essentially tied because all the guidelines basically said, don't treat anybody with estrogen unless they absolutely need it. And if you do, it's the lowest dose for the shortest duration of time. And then take it away after 5 years and let them age, basically is what the end result of that is. And that was because of and incomplete information from that study that was underpowered and not even directed at this.
Yeah.
It was, there's so much to talk about that whole topic, but what it does lead to is a lot of confusion right now. Compounding fill the gap because if you couldn't get certain things in the doses that you need, then it was always available. But how many doctors were prescribing? There weren't many. Most were ignoring.
Yeah. And I think that you really, for hormones and to do it right for women, you have to see them frequently and build a relationship. And I don't even know that the traditional model allows for that. Have you found that in your practice too?
Very much so. It's, much like I see oftentimes other medical conditions that are sort of treated at the minimalist approach and then forgotten because if you take something every day, a cream or a pill or or not a patch, it's every 3 days, but something that you have to take on a regular basis, the levels are different hour by hour. So physicians don't know what to make of that. And they know it's going to be out of their system in 24 hours, so why bother checking labs? And if you give them a minimalist approach, who cares, right, who cares what their levels are, because they don't have guidelines, they don't have anything basis. So really, you should be looking at what is your outcome, desired outcome. You want bone strength, you want cardiovascular health, you want connective tissue support. So you have to have a certain level of estrogen, which the only way you're going to know that is by measuring.
Yeah.
And then that way you can tailor your dosage. Now, when it comes to, commercially available ones, because of the way the FDA processes for any medication, they come in small, medium, or large to make it simple. So there's no half sizes. There's no specific levels or dosage for everybody. That's where compounding also filled the gap, is because if they didn't fall into those 3 sizes, you can at least, or if they don't tolerate the certain dyes or preservatives, then you have to go to compounding so that you can tailor it to the patient's needs or allergies or dose.
And I think that it's interesting when you said also that we were told to take it away and then let them develop diseases and then put them back on. But now it's also like, now that they've developed the diseases and we've taken it away, don't put them on it.
Right.
Because they've been off of it. So again, I think that's something that you have to customize for whatever woman that is and what kind of risk factors, right? You're not absolutely opposed to using it after any period of time.
No, it does become a discussion now. Yeah. So if there's been over more than 10 years, there is going to be cardiovascular changes that happen in the patient that does slightly increase that risk. And if you use the WHI data to determine that risk, it really has to do with the length of duration that they've been away from menopause, those cardiovascular changes. And then what they found in that study was that those increased cardiovascular risks that happen if you start it after 10 years normalize after 1 year. So then what I mean by that, it's a discussion. If patients were only living to 10 years past menopause, which is not that long ago, back in the early 1900s, we were barely making it to the 40s. I think, you'd be fine. Just say, there's no point at this point. But average age of women is now 81.
Yes.
And we all know people that are in their 90s and 100s, which means that women are living to a third to half of their life without hormonal support.
Yes.
So do you want to wait for both shoe to drop, or do you want to address it before it gets worse? They're still going to develop osteoporosis, dementia, and cardiovascular disease by not treating them. At least have a conversation with the patient about whether it's the right time to start, or at least start, something, whether it's estrogen or just maybe testosterone.
Yeah.
Something will benefit them.
Yeah, no, I agree that prevention at all ages is important. That's what we do. I have older people that are just starting, but there's big conversations and there's a customization for all of them. But so the other thing I think it is that we've seen in our practice, again, the core of our business is hormones, because I don't have surgical options. And again, everyone has different tools, and that's what I love, the fact that you have the tools, surgical, and a lot of people are coming to you for that. But if they're coming to you for something else, that you've opened yourself up to all those other tools as well. But when they come with hormones, frequently there are the sexual wellness, issues that it goes hand in hand. But what are some of the services that you offer if they have, the functional changes that they want to see improved?
Sure. In a non-surgical realm, options would be, so of course, local estrogen is always going to be key. It should be in the water pretty much after menopause. So in patients who don't need surgery for decreased sensitivity, decreased lubrication, painful intercourse, what falls under the GSM title, or genital urinary syndrome of menopause, for those patients, if they don't respond to estrogen, laser therapies work, radiofrequency works, any of the energy-based therapies can benefit GSM symptoms. If orgasmic decline, really optimizing their hormones, looking at normalizing their anatomy if there's anything that needs to be corrected, using intimate focused peptides like PT141 or bremelanotide works wonderfully.
Yeah,
oftentimes in combination with oxytocin, and patients do wonderful. It's really about understanding what are all the patient's concerns so that you can come up with a succinct approach.
A plan for them. That's complete.
Right.
Yeah.
So hormones is oftentimes a root cause. Peptides come in really great handy for that, for the longevity aspect, but then also structural changes that need help. So you can correct, support, and maintain.
Do you find your women are loving PT141?
They do. They do. We have a particularly compounded combination that we call the thrill pill. So
Okay.
we have bremelanotide, PT141 with oxytocin, and tadalafil. It's
Okay,
a great
yeah.
vasodilator, and they work great. It's a great combination.
Are you doing that in like pill form, troche?
It's in a troche.
All right, yeah. Isn't that interesting?
Yeah.
I like that combination. So that's what I was talking about today. Again, blood flow is such an important issue because the clitoris is an erectile, the equivalent of a penis, and we don't talk about blood flow with women.
Right.
Yeah.
It's so funny how we become dogmatic in the way we think. We think testosterone's for men, estrogen's for women. They both need both. They both can't live without both.
Yeah.
Tadalafil or Cialis was FDA approved for men because that was the target market that they tested it in.
Mm-hmm.
We're still the same species. Tadalafil works wonderfully in women.
Yes.
PT141 or Vyleesi was FDA approved for women. Guess what? It works really well in men.
Yeah.
So it's a matter of, yes, there's a lot of off-label use when it comes to longevity and hormonal support and sexual health.
Yeah.
But there's off-label use in all aspects of medicine. This is not unique to just these wants. Even in OBGYN and obstetrics, there's plenty of off-label use of medications that were never FDA approved for the condition what they were used for.
And I think that patients are starting to understand the off-label use a little bit more, but even the lasers, for instance, the laser companies will promote it from a urinary incontinence, but they won't talk about anything from a vaginal regeneration standpoint.
Because they can't.
Because they can't. But I think that's where the innovators come in, because everything, to me, is a suggestion, right? Like they're guidelines and suggestions, but you can take the science and you can try to practice it in different ways, which is what you're saying.
Yeah.
We're using it in different ways that aren't guidelines,
Sure.
or aren't approvals, and that's the FDA approval of anything like devices otherwise, because physicians can and always have been.
Right.
And I think there's probably more of an off-label use of everything in the U.S. than not.
Oh, sure. I think worldwide, the FDA doesn't govern physicians. It governs products and medications and drugs and pharma.
Yeah.
Anything that comes to market for the best interest of the patient, but they don't regulate us.
Yes.
And so when they have an indication for something, it's because that's the money where it went from pharma or whatever to create that medication, not because it couldn't be other indications. Look at Botox.
Yeah.
Botox has been around for a long, long time. It took 10 years before we got indication for overactive bladder, right? Because you always have to start somewhere and then find other indications. Just like
then it costs money to get them to get the other indication too.
it does, money and time.
But you can use it
Yeah.
and get the results,
Sure.
but it doesn't cost them money. Yeah, it's just interesting that patients, I think, are starting to understand that a little bit more. But again, if it's an FDA-approved device we're using, but you're using it for something different, it's okay from a physician standpoint.
Absolutely.
But we just have to look at the science. And I say safety, like, is it effective? Is it safety? Or is it safe? And if the results, and vaginal rejuvenation is one of those, where in 7 years I haven't had issues with lasers and doing a regeneration of tissue.
Absolutely.
And we've had results, maybe not 100% of results, but like, again, it depends on the patient.
It's all patient selection, 100%.
Yeah.
And having knowledge and expertise using those devices.
Yeah.
A laser is not a laser. Every wavelength has its different properties. Every device has its unique delivery. But then on top of that, then there's the expertise of the provider. So it's not just seeking a laser; it's seeking the provider's experience with certain treatments and conditions.
Yeah.
Because we have several devices in our office, and it really depends on what we're treating. And even within those devices, we have different protocols depending on the condition.
Brings me to another point, because you do a lot of aesthetics too. And again, I think that's just a natural, like, that people feel better. They come, they want to, because again, our core business is hormones, and we've done aesthetics the entire time. But I think that patient, once they feel better, and obviously they want better sex, but they want to look better. But I think that when it comes to that, there's so many med spas popping up. But I think what we talked about earlier is ones that are physician owned, like yourself, that you're directing with the things you just said. Again, there's lots of lasers. I say there's very limited technologies, but there's lots of brand names, so it gets confusing. But it's really the user. And so when we run into issues, it's really the fact that we have a lot of people operating them that might not have the guidance they need.
That's why it's very, very important for those that are interested in the longevity space, the hormone space, the intimate wellness space. They really have to train. You have to invest in your education, seek courses, attend lectures, go to conferences, and then hone those skills, hone your knowledge base. Don't just buy a machine.
Yes.
It's the worst way to go, because
Yeah.
when you we buy a machine, who's teaching you but the rep? And the rep is not a provider. They're just teaching you the safest protocols that they can make recommended, but they may not serve each of your patients. So it really requires an investment in your time and education to better serve patients.
Yeah, no, I agree. Lasers can be dangerous, but you really have, I think the trainings are always very basic, even for across the board, whether it was the intimate ones that we do or whether it's the aesthetic.
Sure.
You really have to progress that after and carefully.
Absolutely. I think, particularly physicians, we're so used to being trained because we already pay for education. So then somebody should be including that in ours. So if we're going to buy a device, we should learn from them. But reality is they're not physicians. These device manufacturers are not physicians. And even if they have medical guidance, which they all do, they are not allowed to teach. I mean, they can teach you how to use the device in a safe way. It's really up to the physician to invest in their education. And because physicians are leaving insurance practices and going into self-pay services, it's a hard jump to understand that you have to go and pay for your education. And you have to dedicate the time and money for it. And it will pay as well back in spades, because this is something that you've never learned in med school, residency, or fellowship.
Yeah. Well, even plastics, when it came to injections, they don't learn injections in medical school,
No.
but people want to go to plastics for injections. And
They
so
still have to do an aesthetic or cosmetic fellowship.
They still have to learn. It's a constant lifelong learning. It just depends on what the interest and passion is for
That's
it.
right.
Well, I don't think that there's anyone more skilled than you for doing the intimate wellness, because again, you have the surgical tools and then you have all the non-surgical, so you can offer comprehensively with a package or a treatment plan to the results that the patient really desire. And I think that's rare. And I think that there's a lot of patients that'll be watching, and a lot of times they'll reach out to us because I think there's less women on YouTube right now, but I think when we're trying to drive that over from a social media aspect, because I think I'm on YouTube all the time learning. I do that a lot.
It's a great platform.
Yeah, but I think that when they're always looking for places. And I think the big thing for me when I look at the aesthetics industry, and I think the wellness is there too, but the sexual wellness is kind of like an untapped area. That it's been a little chaotic with aesthetics because there's med spas everywhere and everyone's trying to do that and they're dabbling. I think the physician-owned ones that will be the ones to go to when you're talking about med spa, but we're not talking about a med spa with you. Yes, you do it comprehensively, but it's just one aspect of your business. And I think they try and dabble in weight loss, they try and dabble in hormones. But I think when it comes to sexual wellness, like what you're doing, because that's the core of it. And so then it expands just to you're treating the whole patient. And I don't think there's very many practices that do that. Well, I'm glad that we got to connect. Maybe at some point in the future we can do remotes too. But I think that Swan Intimate Wellness in California, and he is looking to open other locations, and we know it's a huge need.
Yeah,
and
for sure.
I mean, it's a need nationwide for sure, because there's just a gap. Women don't know where to go. But when you can go to somebody as skilled with such a comprehensive offering, definitely something you want to look up. Swan Medical and Dr. Peter Castillo.